professors on no pressure. Grand rounds visiting professors discussing diversity, equity, and inclusion. This is part of Dr. Dacus' series of speakers. You know, Dr. Dacus in his role of vice chair of DEI I've tasked him with getting recruiting speakers to discuss this topic, which can be often a challenging, very challenging topic to discuss, but something that's incredibly important, particularly now in this day and age. So I'm very fortunate to introduce our speaker for this morning, one of my close friends who we met during the Honduras mission trip several years ago through ASSH. But Micah Sinclair is a associate professor at the University of Missouri, Kansas City. She's from Kansas City, Missouri. Can never get it right. And she's a pediatric hand surgeon at Mercy Children's Hospital. She is very involved with the diversity, equity, inclusion efforts in her hospital and her department, and leads those efforts. She's also the director of QI for her department and runs the medical student research program. She's been a young leader at the Hand Society and is the chair of the government task force. So she's the one that's advocating for hand surgeons through AOS and visiting DC on several occasions and meeting with senators and congressional members to advocate for our society. So, but her main area of interest and focus is in DEI, and she's recently contributed to a chapter that we wrote together on this topic here that she's going to discuss with us. And her second topic is going to be sort of her life story, which I think you all find incredibly interesting. So thank you, Micah, for coming to Charlottesville and meeting with us today. Thank you for the great dinner yesterday with our residents and some of our faculty, but really pleasure to have you here.
Thanks. Okay. So, of course, as usual, there was some IT stuff going on up here. So just like in the operating room, you know, nothing ever goes right away. But then you get underway and you're in the middle of the case and things are making sense and moving smoothly. So excuse me if there are a couple bumps along the way as I get started here. Working off a couple different computers. Hopefully I have to remember where the microphone is too, right? It's right in the middle here. So as Dr. Schaber said, I'm going to talk about the topic of diversity, equity, and inclusion. I think that different people put the words in different orders, and it has to do sometimes with which one is at the forefront of the discussion. And so certainly with diversity, we want to also make sure that it's not just having a diverse group of folks or thinking about diversity, but that we're actually also including people. So like Dr. Schaber said, I had the great fortune of writing a book chapter with him about this recently. And one of the quotes that stood out for me when I was going through all the literature was, and it came out of actually a recently written book, that a truly inclusive culture is one that accommodates all the ways that we're different from one another, and that it does that intentionally. And so everyone has a different awareness of what's going on around them. But I would say that in my experience and the relationship that I have with Dr. Schaber and Dr. Dacus, I think they're really exemplifying that here. And so I just put up the photos here to show you my lens of how I know them. You all know them from a different place. And I'm so fortunate to have Dr. Schaber and Dr. Dacus in my life to be here. So I met Dr. Schaber on a trip to Honduras, like he said, and he has quickly become a mentor for me since that time. We did spend 7 days together. We breakfast, lunch, and dinner in the same operating room. So if you all haven't been on a trip like this, oftentimes there's two surgical tables in one room. So we weren't even separated at the times that we were operating. So you get to know somebody pretty well. And he recently received the Dr. Green Mentorship Award from the Hand Society. And so I think that was one of the like a huge accomplishment for him. So I don't know if you all know that, but he does a lot of things around here, and just this recognition is a big deal. And then Dr. Dacus, I have the great fortune of we only met recently, and so he trusted Dr. Shabra to bring me here. So thank you, Dr. Dacus, for doing that. These are the ways that I've interacted with him. He is, I don't know what, co-chair of the DEI task force for the Hand Society. And so I actually think I'm not even sure if I'm on it. I think hopefully I am. So that's our relationship. So just to set that up for you all. So before I get into the discussion about DEI, I just want to ground everyone in why we went into medicine, why we are doing the work that we're doing every day. So my answer is that I chose it to use my strengths to help patients and other people. I actually, to make sure that I was on the right track, queried the residents of the program, and I got 3 out of like 20 to respond to me, and they all said the same thing. Everybody felt like everybody has gone into medicine because of this. I had the great fortune of being at Georgetown, and when I walked in for medical school, and when I went to the interview after I'd been at a couple others, they were talking about cura personalis. If anyone's been Jesuit educated, you've heard about this, but it's really about caring for the whole person. And I've just given sort of the definition of what that is here. And it's just understanding who each person is and putting them into the context of their life when we help make decisions for care we provide to them. So the next note I wanted to make is that in this talk, it's mostly going to focus on our relationships with our peers and our colleagues, but I don't want to lose sight of the fact, and that's why I put that slide first, that what we're doing as we are treating each other with respect, as we're becoming a more diverse and inclusive culture within orthopedics, that at the core of it, it's to be a better service to our patients. And so I'm doing this to focus on the ability of what we can change, which is our own community in orthopedics, so that we can make sure that we're providing the best care to patients. It's really about health equity. It's about that we want to create an environment and a group of people that can provide to the patients this cura personalis or provide equity to all of our patients. So, and that's really about matching their needs for healthcare. So as orthopedic surgeons, this slide means many things, right? But we always have to have a football reference, I think. And so the point of this slide, those of us who watched a lot of TV in the 80s, do you remember the ad for this is your brain on drugs? Does anyone remember that one? And then he fries the egg, right? And so this is my 3 slide on that. These are our patients. And I think that what you can see is just looking at the color of their skin, who's in the center, right? And who's on the margins. And so football teams, it's just fascinating. Football teams are largely made up of really a much more diverse group of folks. And so our patients, this is what it looks like. In Kansas City, these are our surgeons. So, there's definitely this paradox of who is who, that that doesn't line up, that we have had the same life experiences as potentially the patients that we're taking care of. But this is really where we want to be. So we really want to be where we respect each other and we work together on the same team, and that we are not all going to win the Super Bowl, but that we get there, right? And so the Super Bowl in patient care is, yet to be defined, but or it's defined by where we're working, and it's really getting to that excellence of patient care. So now a couple definitions. So diversity isn't just the color of our skin. which is, you can see that I am in the majority from that standpoint, but it can also be about all of the things on this slide. And so I think what gave me the opportunity to talk to you all is that I'm a woman, right? But it's more than that. I'm also married to a man who is a cis white man, right? And he reminds me every day that he also needs a voice as well, and very much gets one. So we have to remember that we need to talk to each other and find out, what is really makes us tick. So we can have differences in all these different arenas. So then what is inclusion? Inclusion is when everyone essentially gets a voice. It's everyone feels like they belong and has equal footing to help to change the culture or be a part of the culture. This slide comes up a lot, and when I first saw it, it just made sense to me. And so again, back to the orthopedic surgeons, we're visual people, is just, I think what it underlines most importantly is the difference between equality and equity. I think a lot of the discussion is we should all be equal, right? That's part of being American, equality. But the reality of it is we all need different resources to get to that point. And so what you can see on the right side is, although the person on the far right needed more boxes to get there, they can all see the game. So the next thing to think about is, as physicians, I personally have decided that embracing diversity, equity, and inclusion is really just being about a good leader, or about being a good leader. It's about knowing who you're working with. It's about creating a culture that everyone has this voice. And so the one thing that's left out a lot of times in our training is we're told that we're leaders, right? How many of us as physicians are told we're leaders? And then how much education truly did you get on being a good leader? It's left out of much of what we're doing. And so we're not intentionally educated on it. We're taught about the disease process, and then we learn to lead by just watching the people that we're learning from. And so we pick up those styles. And so it becomes, if everybody's looking the same who's teaching us, then we're all going to try to lead in that same way. But to truly innovate our patient care, we need to learn to lead in a different way sometimes. And so you're starting to see that as physicians, people, it's been going on for a while, but are getting MBAs, or a lot of our hospital systems are starting to create these leadership courses for us as physicians. And for you as the residents, I don't know how much here that has become a part of your education, but it's something that we're working on as part of our diversity initiative to get into the residency level. If you ask me, I think it needs to start in the med student level. When I'm interviewing med students, I'm asking them, do you get any intentional education? Mostly to get a pulse check, thinking how we all work together in these group efforts in medical school, but all you get is the name of who's in your group. Nobody tells you how to choose who's going to be the leader and how to be the one who's the follower, and how to actually talk with each other. And then the other thing is we also don't interact really with nurses until we get out into practice, particularly at least our clinical years. And might we even have a better discussion if we start to talk about group management and group leadership with other folks at that level. So it was just interview season, as I alluded to, and I don't know if any of you guys have seen Draft Day. If you haven't, it's on most airplanes right now. So you should get it for free. You just need about an hour and a half. And there are a lot of things going on in this movie, but when I watched it, the thing that I saw is that he was really trying to figure out, for the quarterback he was choosing or the players he was drafting, is like, what makes them tick? Like, what's really at their core, and who are they truly, and how are they going to perform when they get there? And the whole hour and a half long movie is about that, right? And then about how he's doing these these draft picks that is not done in the normal way. And so I just give that to you all as an example of how we might start to consider what we're doing for residency interviews to try to understand like who people truly are. We're looking for who's going to fit into us, but I think we want to start asking like who's the value add to our group, right? How is this person who's coming in going to improve our program, and is their background going to be consistent with our mission, vision, and values? So like what does fitting in really mean? And I don't know the answer. It's a hard question, and it's different in each culture, right? It's different in each department. And so that's something I think that is probably part of the discussion. The thing is, this is the other thing, we ask the candidates to stand out. So until that point, we've been asking everyone to just be different, to shine, to show us who you are. And then you get here and everybody's saying, oh, I'm this good teammate, I'm this good teammate. And then you get here and it's like, then you have to fit into this culture. So how do you take rugged individualism and then fit in? And I don't have the answer to that. But I think it's about how we're creating our cultures of residency and in medicine in general to grow from the different skills that everybody's bringing. The ones that set you apart before you got here, this is a lot of words. I would encourage everyone to just listen to this talk. I think it's interesting on many levels. They got to talking about what a high performers mean or look like. And they talked a lot about Navy SEALs. But this is where it came from. The thought for me of the rugged individualism is they started to talk about that high performers make other people better, right? And so when you're a high performer, you're not just in a group, you're not just a high performer and stand out. You're a high performer and you bring other people along with you. And again, like a shout out to Dr. Shabra and Dr. Dacus is that's why I'm here, right? That's what's going on today. And so that's done with intention. Simon Sinek he is a really bright guy. He's at MIT or Harvard. So sorry, I'm not going to get his credentials just right. But he's the guy who has a TED talk on what is your why that really, if you haven't watched it, watch it. It helps you to understand that you need to have a little bit more would benefit from when you're setting your own goals, having more intention around like, what are you really trying to accomplish there? It's what we do every day when we're going into the operating room, right? With our patients, we know it in that realm. We know it in the patient care realm. It's surgical indications, but it's like how to apply surgical indications to your life. This book is great. He talks about how life is an infinite game. So it's not like the game of football where you can win the Super Bowl, right? It's just this ongoing game. The rules change as they move. And that's not a bad thing. It's because there's growth. And so really when we're making these decisions, it's not always, and particularly in human relationships, it's not always a win-win situation. It's not always a rugged individualism. It is very often a how can we be stronger together, right? And he has such humility when he talks about this. Chapter 9, he calls it the worthy rival. And it's about when he actually met Adam Grant. So Adam Grant is he works in organizational development. Sorry, I think I just got their credentials wrong. And these guys go into companies, they're invited as consultants to go into companies all the time. They've evaluated so many cultures. And so often they would be at speaking events back and forth, but never on the same stage together. And he tells this story that they were on the same stage together, and he had humility. And he said, I feel like you're my rival. Like I'm challenged by how amazing you are every day. And he said this out loud in front of people on the stage, and he got the same response mirrored back to him. And so I think this, as we move forward in this game, this infinite game is like, how can we have those conversations? And the podcast that I just shared about was obviously after this event on the stage. They now are coming together to create more meaningful thoughts and ideas. And it's interesting to hear them talk to each other. So where are we at in orthopedics? Let's get back to the sort of the discussion about diversity inclusion and equity is where we are. How diverse are we? Like, I think you all have heard this probably ad nauseum, and if you haven't, then I'm glad you're seeing this slide. But it's a heavily, it's uneven in gender, it's uneven in race. There's like 6% women and 4% underrepresented minorities largely, and those cross over with each other. So, and I think you can see it on this slide, right? And who's who. And to be honest, so if this is a census of 2018, it's probably from the numbers a couple of years before that. So we may have moved the needle a little bit in that time. But most of the numbers that have been shared, even up to the last year or two, is that things aren't changing that much. So we're seeing more women, but we're really not seeing much change in the way of minority population, particularly the Black and African American surgeons. So while you all have the opportunity to work with Dr. Dacus and Dr. Shabra, there are a lot of places that don't know that orthopedic surgeons can look like these folks, right? And how fortunate you are to be here. And so then this just is a comparison of the data is really hard to sort of get a hold on. And we don't even know, when we talk about diversity in orthopedics, what we're aiming at right now. I think we're still sort of trying to figure out what that looks like. But if we were to compare it to the US population, so this was just published a couple of years ago, this is the unevenness, right? So look at, even far to the right is the biggest one. Like, if our population is 60% white, we have, for some reason, it's 86% here, right? I think that's probably the right number, but not what I just quoted before. But that it's uneven in how many, what percentage of white surgeons we have. So that alone tells you all that we're not reflecting who our patients are, right? So this also shares just how uneven the gender is. This was in that same paper. And the concept for you all, and is, as again, like, I'm growing as I'm learning all of these things, is we're trying to understand what we're aiming at, and nobody has that answer right now. So what do we do? And it's really, think about it this way. Like, if we're going to truly be inclusive and we're going to try to aim at something, we need to aim to lift up the group that's least represented, right? And in most places, that's Black women. And that work is being done, but it's slow, and it's being done by the women on this slide, and there aren't very many of them, right? And so it's not going to get there unless we create more support for them. So on that note, in reviewing the literature, there's not a lot. A lot of the literature on the diversity in orthopedics is around singular groups' experiences. So, like, women in orthopedics, there's a lot more literature on that, but there's very little until recently. There's a couple articles, but not a lot of data on it, of what the experience is for Black orthopedic surgeons. And so they did this through, this group of folks did this through a survey study. And if you ask me, I think that that's what we need to get to, because you can't just put numbers, particularly when the numbers are small. We all know this when you're doing a research study and you're like, that's a really low N, like, right? It's a case study. And so how do you get at what's going on? You have to go and ask people. And so they developed a survey study that to find this out, to ask them to describe their workplace environment, and to talk about what they perceive their opportunities are. And it shines the light on the discrimination that the Black orthopedic surgeon community feels. And so this is real, 90, almost all of them felt workplace discrimination, and including through their hiring practice. I mean, 70% of Black orthopedic surgeons feel that that's been a part of getting hired for a job. So it's subtle. And I'm happy to also, I'm sure Dr. Degas can send this article out. It's probably worth everybody reading. And that's why I like got silent for a minute, just to let that hit. And there are, and I won't go through this, but there are narratives in this. I mean, it's a table of narratives. So I think really important. On the positive side, 3/4 of people felt that within the orthopedic surgeon community, they had a good working relationship with their peers. So, I'm not here to say like we're all bad people, but because we can be inclusive when people are on the team, right? And so I want to applaud everyone for that, because it's important. And then the question came of, what is this? Like, why is there a lack of inclusion? Like, what are the difficulties in getting a job? It's networking, right? It's if there are only so few of you, how do you call your friends that you know really well and ask them to help you? Same thing's true for women. But that's not the intention of why I'm wanting to focus particularly on this recent publication, and it's about sponsorship. Sponsorship are the people putting you forward. It's the same, it's me being here today. So many of the jobs we apply for are getting are through word of mouth, right? It's really uncommon that you're gonna, I feel like I've heard so many times, like if it's posted, it's not a good job, right? And that's not true. I mean, the job here was posted for a long time, but that was with intention, right? So things to think about. The same thing happens in referring patients in your community, right? And finding people to be your mentors. The next, again, like a lot of the discussion around diversity is not coming from orthopedics literature. So a lot of this is coming out of HBR articles, and I would encourage everyone to read them. I'm also happy to pass these along too. And so the thing I want to really focus on this is diversity, and that's what I'm going to get to in the next number of slides is, you can't, I love this. It's not just a add diversity and stir approach. You can't just say, okay, we're going to hire folks that look different and it'll be a win, because it's never a win unless you really intentionally start to create or already have in place a culture where they can not just survive, but excel, right? And that's what we all want to do in orthopedics. And so we have to think about what it is. Should I be worried about the beeps? Okay. And we have to we have to think about what it is.
More people are listening.
Oh, good. Okay, great. That we do in our culture to ensure that everybody has a chance to exceed, to excel and succeed.
Real quick.
Yeah.
I'll make it go away.
Oh yeah, we're getting a silencer, so
Yeah, I hope so.
that's good. This is a good pause. It's like the maybe the 5th inning stretch, if everyone's okay with that.
You should be right back where you were. My apologies for that.
No problem.
Hide. You're back.
Thanks. So when we look to literature, essentially literature, articles that are written, if you're looking in Harvard Business Review, they're going to give you these big sort of ideas: build trust, actively work against discrimination. And all of that is true. And all of those things are things that we need to be doing. And the truth of it is, we don't know how to apply that to orthopedics. And that's actually why the article that we wrote, and why I thought it was important to focus on today, is like, what are sort of the nuts and bolts in our day-to-day work that we can do that helps to facilitate that, right? I mean, if you all walk out of here being like, I'm going to build trust, I don't think it's going to get us there. And I'm not sure it'll get us there when you've all heard the nuts and bolts we think are important. But what you might start to do is see like, oh yeah, we do that here. or we do that and maybe we could do it a little bit differently. And so then because you've heard this, you've got some ideas, you use your voice to then improve it. So now I'm going to just start going through sort of the stepwise of what the article includes. Again, you can certainly go and read it, but and please do. I'm like an infomercial. But I'm not going to ask you for 1999 when it's over. So how do we get there in our organizations? I would tell you that the number one thing that needs to be done is that the leadership needs to commit. And that in my observation, that's been done. I think that's what's sitting in this room today, at least in the Department of Orthopedic Surgery. And you need to designate a leader for that. So again, check, here that's been done, because Dr. Schauber can't do it alone. None of us can do it alone. Think about the work you have to do in the operating room. You can't do it without a scrub nurse, a circulator. You could probably do it without 2 circulators, but that was a side note comment. But you need your partner to talk to about these things, right? Because if you're only looking at it from your lens and you're really not being inclusive, you need someone to also hold you accountable. And allow for cultural humility, so be able to hear the feedback and figure out what direction to go next. And so then I just want everyone to think about also the concept of tokenism. So when you bring in this diversity leader, you also need to give them the tools to make the changes and the power to make the changes. And that, tools in everything we do is money. That's one thing, right? But it's also like the ability to change the lecture series that we're having, to change journal club, right? And to say, yes, we can do all of those things. In order to figure out what those things are, it's best, as we all know, surgical planning, to create a strategic plan, right? And when we're making that, to look at each thing that we do in residency and the work of our organization, where can we consider including DEI initiatives? So that's the part that has to be specific to each hospital culture and department culture. So importantly, recruitment, how do we then, okay, I'm committed. How do I recruit more diverse residents, or more diverse staff, or more diverse faculty? And there are a number of different things that we have to do to get there. So, the important thing is, if you can see it and believe it, it's a lot easier to achieve, right? So when you look at articles that were written in female literature, about women in orthopedics, it's what they've really found is that women are drawn to places where there's strong women attendings, right? Same thing was shown in literature around minority candidates as well, is that when they're coming from medical schools where they see diversity of the faculty, they may be more interested in going into orthopedic surgery. So how do we strengthen the pipeline? Well, we can't even start just in medical school. Honestly, we all know that. If you're applying to residency and you didn't start doing research when you were in diapers, it's really hard to get in. It really is. So you almost have to be born with a screwdriver and a hammer in your hand. And not everybody is. And so we have to get this out there in front of kids who are younger in high school. And so, does that answer the question? Why are there so many more males? If you just think about sports, you're playing hard, you're injuring yourself, you're needing to go to the orthopedic surgeon. So that option exists. How many essays do we read about that? I don't know how many of you review the essays, but it happens a lot. But more and more, we're seeing women athletes as well, and so a lot of times these injuries are how people get into our office. But there are also pipeline programs that we can be a part of. Peri Initiative is one of them. I'm not sure if you guys do that here. You do, and it's 2 levels. It's for high school students as well as medical students to be able to experience orthopedic surgery. So this is the top right picture, and I'm sorry for the spine surgeons in the room, is I was happy I showed up late to that one because I didn't have to do the spine part. But I did enjoy doing the ACL one because basically hand is just small sports. So I was all in for that. The other thing that a lot of different institutions are doing it at different rates, and ours has this, is we have summer scholar programs for high school students in the area to come work in our hospital, as well as college students. And so it's not orthopedic specific, but if I work through my hospital, try to get them into the orthopedics department, they have the opportunity to see it. For the medical students, it's okay. Good. Is that like a code pink, missing child? That's for me. And we have the opportunity for year-round recruitment of the medical students, right? We can give lectures to the medical students. They have ortho interest group. The Perry Initiative, there's a group, Nth Dimensions. I don't know if you're involved in that, Dr. Dacus. And okay, so that's a mentorship group that really like the top right picture is from their website, Lifting as We Climb, because what it has shown is that the students that are involved in Nth Dimensions are very successful at getting into orthopedic surgery. And so how do we continue to amplify through ways like that? People need mentors. The other thing I just want to bring up, and I read this in one of the articles, is we also it's important to look at our digital presence. So I think people are starting to you're seeing that more and more, or maybe I'm just late to the party, but that residency programs are really amplifying through social media, but our websites are important too. And so when we recruit for residency, looking at the holistic application review, we all know, we were talking about this last night, step 1 and step 2 aren't going to have numbers to them anymore. And so it means we're going to have to read a lot more, which is hard for us as orthopedic surgeons. We rather look at pictures, boil it down to numbers, because traditionally we say that if you did well on that, you'll pass the boards. Right. And so that's what we just want people to be successful, and that's our metric. But I think that nobody's figured out holistic application review yet. And so within the department, as we're starting to do that, we have to decide, what are our buckets for what are we looking at? How do we review everybody on the same playing field? What are their experiences? That's the community service part, the leadership part. What are their attributes? And that's harder to understand, is sort of what their core values are. And we don't know what core values are required to be a good orthopedic surgeon, because I bet as many of us as there are here, there's probably a number of different core values. And then reading, but then we have to also be aware there's potential for bias. And this is some work that was done here on the hand surgery fellowship. Yeah, on the hand fellows, is just looking at, and this is, talk about humility. I don't know if everyone knows this, but Dr. Shabra and Dr. Dacus looked at their own writing, correct? To see their own biases. And so I think that's important work to do. And I am part of this, or I'm one of the people on the Facebook group, Women in Orthopedics. And this is what they said, would you ever describe a male applicant as bubbly and energetic, though stable? We just wouldn't. We can all laugh about it. I'll laugh about it. But it's probably not the ringing endorsement I want to go into residency with. When we consider for faculty recruitment, that we're looking at, if you're trying to diversify, it's a small pool of people. And you also want to give people the opportunity to really consider the job at your place. So you're not just going to look and take the job immediately. So you want to publish it early. You want to give time for that. And you want to publish in multiple different locations, right? I feel like a lot of times a job is published and it's just put on one website because the hospital made you do it, but you were already hiring someone anyway. I think we all maybe that side of the room doesn't know that, but PS, that happens, right? And so by actually publicizing these, you might see that you get different candidates that you didn't even realize were going to be an option. And you'd want to be aware also then when they're coming to you applying for the job, they might have just outgrown their culture, right? Just because someone's looking to leave a job, it doesn't mean it's something's wrong with them. You have to put them into the perspective of the greater culture and be aware of the biases that are coming from the people around them as well. So when we standardize the interview process, not just with residents, but with everyone, when we're doing the interview process, I think it's best to standardize it. So how do you get a gauge on how people are different? Try asking them all the same question and seeing how they respond. And have it be a meaningful one. So this is what our hospital gives us just on our website. It's the state of Kansas. I do live in Missouri, so there's some confusion around that. This is free and I can send it along. You may already have one for your own hospital, and you just pick what skill you want to ask about. And then it gives you options for questions to ask the candidate. And you can choose from that pool to see how they think and how they interact. I think another good one that's really basic is just tell me about yourself. And it's interesting to hear how everyone presents themselves differently. Some of them tell you what they think you want to hear, and some of them tell you truly who they are. So we do it with our patients all the time. Tell me why you're here, right? And then look at how we're transforming promotional practices. So what are we getting promoted for, right? This is about having clear communication of expectations, particularly with the residents, ensuring that they have good skill acquisition. You all have the sim lab here, and I asked this question, are you all using it? And it sounds like yes. And I think it's a great place to offer for the residents so that you can train so that when you get to the operating room, you're more ready so that you can proceed through the case longer. So when you hire faculty too, when we're hired as faculty, we want our leadership to commit to mentorship and sponsorship. Some people are even doing mentorship in the operating room. So all that is operating with your junior partner, right? And that part's important to do. I want to bring up, and I'm sorry, I feel like my talk is going to go a little bit long. Is that going to be okay? Okay. I want to bring up just this idea, because I feel like this happens and people aren't really talking about it. So this is a recent publication out of Duke, I believe. That's where Melissa Erickson is. And I'm sorry if I'm wrong about that, Duke or Harvard. And they looked at essentially like how everyone did on standardized tests on their way in the door, and then compared it to how they did on the OIDI. And they found that women and underrepresented minorities were dropping off on OIDI scores. Even though they may have had a higher step score coming in. So the issue isn't necessarily taking the test, it's the experience that they're having during residency. So why, when we invite people in, how do we create our culture so that they're all able to do just as well on the in-training exam each year? Because with that happening, it may be more than just the fact that women and underrepresented minorities are being pushed aside in the operating room. Like, what else is going on? Or is that it? The case gets taken away from you more often because you seem less confident or something. So that's where the skills acquisition, the skills labs are super helpful. So when it comes to the hiring, for faculty, I think we've all seen this, that we need to, it's not just medicine, it's everywhere. But we need to ensure equitable and fair salaries. There's a couple articles that talk about this and then project pay parity for women. And this is what it is. That's the year, right? So maybe by 2059, women will be equal to men in pay. That's like 30 years away. But then if you go to the difference between black and white, that's 100 and how many years away? Like, that's a long time. And so we need to make sure that when people are getting hired, we're hiring for the same job at the same rate. We're looking to help support promotions to make sure that people's salaries are going up at the same rate. When people are taking on leadership roles, ensure that everyone's getting paid for it. I'll just be honest, my leadership role for the diversity work, I'm getting paid $0 for it. And that's often what happens, right? And so these leadership roles that seem like they're so important, we need to put support behind it when it comes to salaries, because truly at the end of the day, like what your salary is how you are valued by your employer. I mean, there are a lot more other things that go into it, but I think in this day and age, a lot of times we boil it down to that. And when we're looking at salaries, again, because there's such a disparity, because there's a big N or a small n and a big N, right? We need to disaggregate the data. You can't just on average say this is what my department gets paid. Like you have to look and see. That's how you understand where these pay disparities are coming from. And I'm not trying to call anyone out because this is going on everywhere. It goes on at my hospital, in my department. Like this stuff's real. And so when we get to the topic of, then, all right, they're here, we've got pay parity, like, okay, what do we need to do to support these, our peers, our colleagues, and how, so that we can keep them here, right? I thought I'd give it a little, throw in some orthopedic support and retention ideas here. Just send it home for everybody. So we want to be proactive in supporting and developing the faculty members, right? So as having regular meetings with our leader, letting the new faculty drive their plan, like come up with what they're interested in like doing in the leadership realm. There are so many opportunities. And use promotional structure as a guide. And make sure that they're not alone. So make sure that they have a mentor. It doesn't even matter if it's in your own department, because it's sometimes hard to find a mentor that looks like you in your own department. You might have to go, God forbid, to general surgery or something like that. Sorry, well, we love, we would love working together with our teams. Here I am saying diversity and inclusion. But we learn a lot from talking, it's just like politics. You have to talk across the aisle, right? And we have to talk to each other and learn from each other's different experiences in the hospital. Frankly, one of the people who's been a real mentor for me where I am now is a hospitalist. They do a lot of QI work as hospitalists. So that's been, you don't know where you'll line up with people and what your shared strengths are going to be. I think you all do this here, performing annual reviews. I mean, this may come as a surprise and it may not, but I, in 5 years, just had my first annual review last year. It's crazy, right? So, these things go on outside of the walls that we live in, and all we know is our own experience. And I think that's a place to put DEI, the concept of DEI work into is what are you, we can assess for ourselves each year, like what are we doing to move the needle? What space is that in? And then set goals for the next year. And as for the leader of the department, then when they're seeing this work being done, back to the, pay parity is incentivizing to keep DEI as a focus, right? So to hold everyone accountable, that maybe it becomes a part of the work we're doing. And if we do it right, maybe it's your research that you're doing, which already is in the incentive structure, right? So figuring out where to put our focus. I think we want to make sure to be aware, we all know this, that there's potential for bias in patient feedback systems. So I'm not sure that that's a part of the pay, but it's certainly a part of the eval. Each year is the feedback we get from our patients. And we have to remember, and everybody knows this, if you have a patient who's upset with your care, they are going to tell you about it, right? And so the patients have bias too. So they might just be upset with your care. I mean, for me, because I'm a woman, right? So they don't know that. They're not writing that. But I think as you're going through your patient evals, you can't not think about that, right? And then if things are coming up consistently, like this doctor is always running behind, don't focus on the doctor as something's wrong with them, but maybe make sure that the system is supporting them, making sure that they have the same, a scribe, an MA, whoever is in your system, like, do they have the same number of people and access to resources to support them? And then being aware of potential bias in productivity models. So, that's really down to a referral thing. Where are the referrals going? And the other thing is, and I don't know what the pay structure is here, and it doesn't matter for me, but a lot of places there's an issue of who's getting the Medicaid and Medicare patients, right? Because you're getting paid on collections. So where are those going to go? They're going to fall to the younger surgeons, right? Which means that the younger surgeons, it's going to look like they're less productive if you're looking at collections. And it just leads to this bad spiral. And it also doesn't serve the patients very well either, right? Because then they are getting aced out of the access that they need, sometimes more than the ones that have access. So it's important to have a family leave policy. I think the thing we need to start bringing into this also is that men should be given time off to be with their family. It used to be, it's so often a badge of honor that that people have missed their kids' delivery. Like, I'm not sure why that is. When you agree to get married and have a family, you're part of the family. So, that's while the kid doesn't remember it, it still is meaningful for your spouse. And so, the other component of that, which everybody does differently, but we need to think about is, what do we do when people go on maternity and paternity, so family leave? Do they have to make it up? Why is it a punishment? It's already, you're using short-term disability. So pregnancy is a disability. So just like, these are things to think about. No one has the answer for that yet. Right. But one of the challenges for women is that we're already delaying starting a family. And because of that and the stress, a lot of times it requires fertility treatments to have one. And this is a same kind of an article where it was a survey study, but women are carrying more responsibility at home as an orthopedic surgeon and a mom, oftentimes than their spouse. And they're then not able to take on academic or leadership roles because they don't have time for it. And then they're earning a lower income. So it's cyclical, right? I'm not giving any answers on what the right thing to do is. I think that's situational in each culture, but just things to think about. And the next thing I would say is, it's the leadership part, is giving opportunity for leadership education, right? We all need it. It's going to be a different fit at a different time in our careers. So our bigger organizations have it. My own hospital has one. I think there's one here. Our AOA has it for us as orthopedic surgeons. POSNA has just developed one. When you sign up to do leadership in AAOS, they do have levels that you go through to train to be a leader in their organization. So you're seeing it through that lens, but it's the same skills. Not a lot of places are doing this, but when you're then developing, you're creating leaders, you're developing a team dynamic, it's helpful to have that conversation together about what people's skills are. And it goes deeper than arthroscopy skills, micro skills. It's what your skills are as a person. Some of us think we're, quieter. Some of us are more outgoing. And so how do we, as orthopedic surgeons, we don't know how to have that conversation. So finding a tool that helps us to have that conversation. This is one of them I found to be helpful. It's called Clifton Strengths. And it's validated because so many people have done it, and it has a positive focus. So it's, what are your strengths and what do you, again, contribute to the team? I would say that when going through that, everyone can take it individually, but it is helpful when using it as a team to have a facilitator for it, because they're trained in it. Sort of like, writing the instructions on how to put a cast for the cardiologist. It's probably not going to go as well when they're doing that, right? Like when they tell us how to titrate the beta blocker for our patient, we know how to do it, but it's not as successful. And then sponsorship. So providing all faculty opportunity for leadership roles. So be intentional in the selection, line it up with what they want to do, because it'll be more successful. And this leadership opportunities are in so many different places. And you heard that when I was introduced. They can be in your department, your medical school, your hospital, national organizations. They don't even have to be medical, but help people to align with and get into leadership positions, because we learn a lot from that we then bring back to our patient care. And then hold people accountable for personal growth, right? And respecting each other. There's education that goes on because it needs to, because it helps facilitate the conversation and gives us language around what we're experiencing or thinking around bias, around microaggressions, around being an ally and how we communicate with each other. So there's a lot of, conversation around, should we do this? Should we not do this? I think that we need to do it, but it's so that we can have a language and to know what's going on and what we're experiencing. But then we need to hold people accountable and not tolerate those behaviors. One thing I think is important too is to require community engagement and somewhat on a routine basis. And I wrote feasible timeline because that has to fit in on the pay structure as well, right? Like if I could go on an abroad trip every 3 months, it would be great, but I can't because I am committed to my hospital, right? But if we can get the residents out once a year to do an event that they're connecting to the community and seeing the community more than just in the emergency room, then they get to know their patients better and they understand their patient care better. A lot of people get involved in Big Brothers, Big Sisters, which I think, Dr. Dacus, you are very involved in that. And that just really helps you to understand truly what your community is like. It helps you to understand who marginalized, populations are in your community so that you can help to provide better care and access. And then celebrating your faculty. And there's ways to do this. You can do it at faculty meetings. We all have internal web, social media, marketing, but to do it evenly. So when people are doing good things, to make sure that you're letting your leader know if you're not the leader, and as the leader, figure out where to put that information so that your community knows the amazing work that you're doing. Another thing that is super important is that we need to improve health equity through our research, right? And diversity. And you're starting to see grants that you can apply for specifically for this. So how can I develop my research to aim at a grant like this? And how is it going to be meaningful? You can use grand rounds. That's why I'm here today, right? That's why the enough said on this slide. And then really, so that's all like positive or like proactive things you can do. The thing we have to remember too is when we're working on culture change, people are still going to complain. There's still going to be this discussion. And so how do we handle that when it happens, right? We don't just blame the person where something went wrong. It's like, you have to take it like a root cause analysis. The patient gets a wrong med. Is it the person's fault who gave it to them, or is it the pharmacy, or is it somewhere in the EMR? Like where was the breakdown in the system? So I think that we have to remember when challenging situations happen, that as leaders, we need to do due diligence, right? We need to figure out like, what are all the surrounding things that went on? And as a leader, we're again, not trained in that. And so a lot of places will have an ombuds program or an ombuds person. It's really just about having a neutral third party that can listen to the story on all sides. We all know that when we're in a conversation with only two people, there's 3 ways to take it, right? And so that's part of it. The other is having a pre-existing relationship with your leader, with your faculty, so that you know who they are, how they're doing, what they're thinking. And you might know, like, okay, like they yelled in the operating room, for instance. I think everybody has heard about somebody who's done that, right? Well, maybe they're going through a divorce, right? And so that doesn't mean that you don't have the conversation with them. It just means that you're able to see where they're coming from, what's going on for them, and it doesn't spiral into this. It gives you an opportunity to figure out how to support them differently so that they can move past what's going on. And so again, so that leads also to surgical complications are difficult. And that's another place we don't have processes around, like what happens. We present them at M&M, right? But people get sued. And even if you're not getting sued, you're sometimes stressed out because you just show it at M&M. You'll hear me talk about that in my next talk. And how do we process that? So the next time we're going to do that case, we go in with confidence and we do it the way we know we can and for the best way for the patient. So it's, we want to make sure that we support people when they have complications. Someone looked at this and for women, because in the referral realm, like complications on the referral standpoint for women, primary care doctors will refer to them less. So if women have a complication, they'll lose 60% from like the physician referring patients. For men, it's half of that. So I think we just want to be aware too what goes into these referrals, right? And complications happen. So again, like I'm not giving any answers here, but it's just something to think about, is how do we process those better? And then recognizing signs of burnout. So I don't know if you all have seen this. We talk about burnout out all the time, but specifically for the orthopedics community, 1 in 4 physicians who commit suicide are orthopedic surgeons. I don't know if you guys all knew that, but that's terrible. And there's probably a lot of reasons why that is. But I think that we need to think about that when we're holding awareness for who each other are and talking to each other about what our culture is like. And there are higher risks of burnout for women and underrepresented minorities. And so, you know, this is real. People are starting to talk about this, and this is where we have a real opportunity to make improvements. So I don't want to end it on a negative note. I'm sorry. I'm going to hopefully go into a positive talk next, but I just want to go back to, there's one more panel in those slides or in the sort of cartoon from the beginning, is it adds justice, right? So that's what we're talking about today is when we get to equity, how do we get to justice? How do we get to the place where we fix the system to support everybody? Obviously, we don't have that answer, but me being here today is a part of that. And so I want to thank you guys all for listening to me talk for this long. And thank you to Dr. Schaber and Dr. Dacus for giving me the microphone. So happy to take questions.
Yeah. Questions? Dave?
Dr. Weiss, they told me you were going to ask questions. Good answer.
A lot of, I'll speak on first level. So I like your slide about interest and commitment. I feel like I'm very interested in diversity. I don't feel like I'm committed because I don't feel like I have to help besides saying, oh, I want to have more diverse environment. I want to listen to different people. I don't try and shut people down. But then I sort of like, well, now what do I do? How do I? A few years ago, for interviewing for faculty, and like we want to hire women. Interview and try and be next talk. I've earned enough work here, so I don't feel that my sense. I've earned enough work here, so I don't want to do this. Taking on that role that you're talking about. So then you start thinking, what would you? Sure, what we're supposed to do next. You have a lot of different ideas. They're helpful in posting medical students from underrepresented minorities and and giving them scholarships to come here to try and support the time it takes to live at a place here. What else?
Yeah.
What else we do in particular?
Yeah. Those are awesome questions. And I think that what you can be doing is start by asking the question. And the folks in the room can help with that answer. You know, I just say having a conversation with Dr. Dacus, who's the leader of this initiative, and saying like, where can I be of service, right? And it may mean, can you mentor an underrepresented medical student? into orthopedics. So, and maybe you're already doing that. But it all, and so if you are, I'm sorry, I'm giving you an idea that you've already hit on, which, or something you're already doing, but even that alone, like, sometimes we hit a place where we don't know how to answer the question that our mentee is having. And so you have to ask around and figure out who can you talk to about things. How can you get them across that? Don't always need to have the answer, even though in orthopedics we think we do. Not just we think we need to have the answer, we think we have the answers, right? And so some of it's that humility and recognizing that we don't, and asking somebody else, even when we're the leader in that, right? Even when we're the mentor. So I think that's like probably the answer for now for me. You probably have a lot of places to get engaged. I don't know.
And I think it's some of it is open to the fact that you don't that person is coming here. That's very important to say. Know this.
That actually, sorry, do you want to go next?
Sometimes hard to say that and go, okay, yeah. There's no way to prove it because you have to start. Since it has been set phase that it's gonna happen. Yeah. I think we're very open, or if you look around the country at orthopedic departments, we're certainly one of the most diverse. But I think the people here are also very committed to working together. I often say that of all the academic departments that I've been involved with, this is by far the most engaged, supportive. I think that goes a long way.
Yeah.
To doing some of the things you talked about, which is establishing trust, learning to work together and accepting where other people come from.
And that models it for the residents. And then they're going to go out into the world and have practices like that. And so I agree that that's super important. And hopefully they will.
I think the key, you need a pipeline, but the most critical thing for me as a chair is that when we recruit people, who are underrepresented in orthopedics, it is critical that they succeed here, and they have to succeed so that you open up the pipeline more. So if you see individuals succeed here who are women in orthopedics or underrepresented minorities or less represented in orthopedics, if they're successful here, we're in a small community ultimately, and you will see others be interested in your program because they can see that the support is here to be successful, whether that be in research, education, clinical care, or across the board. So creating a culture and environment is something that everyone has to be committed to, so that we find ways to help our residents and team members, faculty succeed. And if they're struggling in certain areas, we have to figure out how to support them, as you mentioned, and provide them the resources so that they can succeed. Because if they don't succeed, I think it makes the task even harder in recruiting from that pipeline. If our medical students don't see faculty succeeding here and residents succeeding, then they're not going to want to stay here. So it's going to be hard to recruit those in.
Because people see that. They see that people don't succeed, right? So that's the negative message rather than the positive message. Do you guys take a break or how do you do?
Behind, so everyone's
My
got,
fault,
yeah.
sorry.
So you might want to just move forward then.
Can I just make a gendered comment? I mean, women are always running behind, right? Like you guys, you guys have to wait. So I will, and you might see a answer a little bit for what I've done in my own work to try to answer that question. So thank you. Talk. And I've entitled it Curiosity as the Roadmap for My Life. So I decided my second talk was going to be about me because that's part of the process of inclusion, right? To hear other people's stories. And on my journey, I've been like constantly challenged to gain insight in who I am. And why do I feel like I'm in a profession as a leader? And I think as I have done some leadership education, I've come to learn the importance of curiosity, and I've recognized that in myself, and that's what continues to drive me forward. This picture is, my mom is not the best photographer. This is like she's so proud of this picture of me when I was little, being curious and like in nature and science, like she thinks it brings everything together about me. So, and apparently I still wear my hair the same way. So she insisted that I include it in my talk. Hold on, I'm stalled out here. There we go. So a couple like formative experiences that keep coming up for me. So I think, as we do this work on understanding who we are, we go back often to family of origin stories, and that's an important part of the work. It's an important part of defining who we are. So, what lessons did my parents teach me? And one of them that I just laugh about quite a bit is sailing was a thing for my dad, as was golfing. And just on the gendered thing, it was always, this is my older brother with me, like he's the one that went to the golf course. I didn't go. My dad thinks that as a woman, I'm capable of doing everything, but maybe had this blind spot when he didn't take me to the golf course. And I wish I knew how to golf, but I don't. But he did take me sailing, and every time, so this is on vacation, that's why I think I'm smiling in this picture. But at home, he had this little racing boat, and whenever it would be a super windy day and the trees were going sideways, he'd be like, "Let's go sailing." And so I don't know if there are any sailors in the room. I am not one because of this. But I recognize that we would go out and I would be screaming. The boat would be sideways. I'd be in this little, 1980s, life preserver, like holding on for my life. But every time we'd come back to shore and I would have survived, right? And so it's a wild ride. Like sometimes we're just on this like windy sideways ride, and whether we're screaming out loud or screaming in our heads, we're gonna get back on shore at some point. And so then the other one is about my name. So every time, so this is my brother, again, we're 18 months apart. His name is Alexis. Right? So envision when you're a little kid and you walk into the room, you see Micah and Alexis, and you get it switched. So, why did my parents do that? They didn't get an ultrasound or anything to figure out if I was gonna be a boy or a girl. I won't get into the Alexis thing. They tell me it was a Russian author who's a male. But for me, they liked the name because of, in the Old Testament, which is why it's often a male name, the Bible verse, I was gonna say quote, that gets quoted a lot is about these aspects, right? These values of justice and humility and kindness. And my parents wanted that for me. But it took me until medical school to figure that out, because I was always like, yep, I'm just Micah. I'm always apologizing for myself, right? You expected you were going to get a guy, but you got me. And so it set me up a little bit for orthopedics, because I'm just used to people asking me if I'm somebody else, right? Are you the nurse? Are you the PA? Are you the whoever? So, it's a gratitude to my parents for that. So the next one I think about is a third grade experience where my mom got a call one day. Oh, a side note on this picture, when I got it from my mom, I have a camera, which I think means I was just made to be a hand surgeon, right? Because we take so many pictures in the operating room. But the teacher called her and said I asked too many questions. So like, what is that? And now as an adult, like I have so many questions about that, right? But her response was, I'm putting her in a different school. Like, this isn't serving her well, right? She's curious, she wants to learn, and you're going to shut her down. So she put me in a new environment, and that's really fortunate. And so she sent me to try it out one day. And I got in the car and said, Mom, they just like kids here. So that was that. Like, I went to a different school that next year, and it was great. And as I reflect on it, it's like, why wasn't curiosity welcomed? Was it gender norming? Like, or did she think that I maybe needed an IEP? Like, what was it? What was she trying to tell my mom? I don't think my mom knows either, but my mom appropriately supported me and allowed me to be curious. So the next stop on the train is then, all good things have to come to an end. I'm back in Catholic school again. For all of us who went to Catholic school, I think we understand that statement. And all girls. So I looked on their website this morning to figure out if that's the right term. I think that term is still used, but it's also can be all female. I tested in, and I was in classes again. I was like, not that this is bad, but a little bit of an outsider. I was in classes with all the sophomores as a freshman, right? So I wasn't being like academically challenged, but these two women they actually were roommates with each other, which I learned later on in life, but they were my favorite classes. And I don't know if I took that, like I had to take chemistry, but I think I took Latin because my parents always told me I was going to be a doctor. Right. And this lady was awesome. And I still remember Latin, and it really created a foundation for what I'm doing now, because I understand the words that we use, and it's like in my brain already. Right. I don't have I don't struggle with it the same way our patients do. Right. We use words with them, and they just look at us like, what are you talking about? You have polydactyly, and they're like, what is that? I think dactyly might be Greek, but you get my point. And then Sister Harriet was this like, man, was she tough? But I learned from that class that really how I tick, that like, if you give me the tools or the concepts, I can put them all together in the end. And I love that challenge. So I don't know if any of your chemistry teacher did this, but she did an unknown at the end of the year, which meant she gave you a substance, and you had to go back and figure out from all of the labs you did all year long what she gave you. That's how I passed chemistry in high school. And all through that year, I was tutoring all of my classmates to get there too, right? And so that just, when I think about it at the time, I knew it was important. And when I look back, certainly I realized how important it was, what she taught me about chemistry, about myself, and about how to think. But I still didn't feel like I fit in there. So I took a cue from my mom's cue card and switched schools. And when I got there, the teacher I had said, don't expect her to get higher than a 3. So, again, it's this like, what's going on here? Like, why are these things said about me? Well, at least I got a 4, but I think I remember that really well, because the essay question on that exam was directly related to what has gone on in the United States when busing started, right? And that happened, it affected Kansas City, because we're on a state line. Like, a lot of people moved to Kansas, and a lot of like the white community just moved across the state line, and the school systems are very different on the different sides of the city. And so I knew that well, because I was living in that community. So it just shows also like how important our lived experience is to our success, right? So moved on to Georgetown and I was a chemistry major, and I wasn't like sure that Georgetown was for me, but my dad was sure. And at the time our applications, we used typewriters. I think probably this is like this half of the room, and maybe some people back there remember that, but we did. And so he had his administrative assistant fill it out for me. And I'm guessing that she was like, what do I put here on what she wants to study? And my dad was probably like, oh, she was good at chemistry. So, I show up and I'm like, I'm a chemistry major. Like, and I showed up to a roommate from Kansas City. My roommate was from Park Avenue, right? And she's Chinese. And so I'm showing up to a place being like totally like, now I'm studying chemistry, and I'm meeting this woman who's grown up in a totally different way. And there are so many formative things that went on when I was there. But just to say that we lived together for all 4 years, and we learned a lot from each other. And so that was like, we're still friends today. This picture was not too long ago. And so I felt like that was, again, another like growth opportunity for me. When I was studying chemistry, I was like, what about this medical school thing? So I made sure to add biology. So I would have all my pre-med requirements done. I took the MCAT second semester senior year. So I think we all know what goes on when you're graduating from college. Like maybe the MCAT, I could have done a little bit better on it, which was a part of, a challenge for me, something that I had to like work through and explain. So again, when I'm having these interviews with folks trying to get into medical school, I'm having to share my story. So what did I do? I wasn't sure if I wanted to be a doctor. I decided to be curious and like dig deep and figure out like, what have I always been curious to try to do? Like what's been left out of my life? And I had growing up a lot of friends that would do these outdoor adventure things. And so I found one that was a leadership course. I always would have a summer job. So I found a leadership course to do. And it was for a semester. And you can imagine how, my dad, who had like supported me through all my education, felt it was this like, what are you doing? Why are you going there? And it was probably the most important decision I've ever made in my life. So my husband was on the course, my now husband, then I didn't know him, he's from the West Coast, was on the course doing the same thing. He was pre-med, he was trying to sort it out. And so we've like journeyed together ever since then. And it's been an adventure. And so I was glad that I was curious about what I did, because he's really been a supporter for me as I've gone through the whole process of medical school and residency. And honestly, like when I get calls, he usually knows what to do. Or he could take the OID better than me when I was in residency sometimes. So like, it's just good to have a partner that can help support us through these things. So when I got to, so I did decide I wanted to go to medical school, and applied, and again, had to explain, like, why didn't you do as well on the MCAT? And thankfully, like Georgetown, I don't know who spoke up for me, and that's the stuff that goes on phone calls behind the scenes. Right? They took a chance on me, which is great. And while I was there, my husband and I got married, so he was still coming along for the ride, and I was getting involved in everything I could, mostly sports things, right? And I was for sure I was going to do something internal medicine. There was no way I was going to be a surgeon because I didn't have any experience with that. I mean, I was a high school athlete, but like not the kind who tore my ACL. Maybe I just didn't play hard enough, but so then I get to my third year rotation, and I'm sorry he left, but Brockmeyer was there as a resident, right? So like you probably all know something about the Georgetown community. Like you just med students come through all the time, and now Dr. Schaber's brother-in-law is there, right? So you have some sense of this, and they send a lot of people. They really educate well on orthopedics. And I learned about that orthopedics was just like chemistry. It fit for me, right? And so did surgery. Like I fell asleep on my internal medicine rotation rounds and I'm getting yelled at. I get to surgery and I'm like rolling up my sleeves and working hard. And I was like, oh man, I didn't plan for this. Like I wasn't born with the screwdriver in my hand. And so it just led to, I knew this is what I wanted to do. But it was going to be a more circuitous path for me to get there, right? And so I go to interview, and this is the challenge of being a woman sometimes, for the chairman's letter, and this was the advice I got, right? Like, you'd better get lipstick and a push-up bra. And I was like, well, like, what does that mean? I own an underwire bra. Like, does that count? So it just was, at the time I was like, yes, sir. Like, this is what I need to do. And I'm pretty sure my letter was like mediocre at best. It just was like, she has a pulse and she wants to be an orthopedic surgeon. But yet they didn't leave me, in the, like, alone when I didn't match that first time. they helped me figure out what I was going to do. And so I ended up going to Loyola. So here I am, like back in the education system, Jesuit, but that's the cura personalis part. So I like really feel like I benefited from being in these cultures. And so when I got there, I met with the PD and I met with the chair and I said, what can I do? And I just worked hard on all these rotations that aren't normally a part of orthopedics. I did take the OID and I started running. And I re-entered the match, and I will never forget when Lieutenant Colonel Hopkinson, the program director, said, "You can run a marathon, you can be an orthopedic surgeon." That's what he said to me on match day. So I stayed. They took me on, and they gave me a chance. And I think part of that is because they knew me and they saw how I functioned and how I thought, because I was there for a year. And that led me to hand surgeon mentors. The chairman of the department was a pediatric hand surgeon. So that might answer for you all, why my career has gone the way it's gone. And he didn't push me in that direction, but I obviously was drawn to it. And not just Dr. Light, but Dr. Bindra was really an important part of it, because he picked me up when I just wasn't sure if that was where I wanted to go. And he started telling me, you're going to write this book chapter and you're going to do this. I'll never forget the days. We've got a guy, and you can still think about was this right or not? But with multiple metacarpal fractures on both hands, he's like, I'm writing a book chapter on metacarpal fractures. So we're going to fix each one a little differently and take photos. Right. And you're going to write the book chapter on it. And it's a little bit about him, right? And making sure that he's getting his name out there, but he's also using it as a vehicle to help me get my name out there. And so that's a really important thing to do. And the last one is the curiosity thing I'm most proud of from residency, is that I made a friend for life. So there were more than this. There were 5 women at one point. And right next to me is Megan Micah, who if you haven't met yet, you probably will this year, it sounds like. And she was a junior resident with me, and we all know how that goes, right? Somehow you get put on one rotation with them and then you track through the years. So 2s and 4s, 3s and 5s. I don't know if that happens here, but for us it did. You track through together. And early on, I hit a challenging time with her. She's very strong personality. And I was like, how am I going to make her create a working relationship with her? And I decided I just learned of this tool to use. I'm going to ask her, or tell her where I think my strengths are, and then also where I think I can improve. And I asked her to do the same thing. And I will just tell you all that it went a long way, and we continue to be friends today. And so it's that having that communication around how your relationship can be super helpful. So mentors and friends. Let me ask you a question really quick. It's 8:30. Do you want me? Okay. When I hit my fellowship, okay, so I go into Dr. Light's office to tell him what fellowship my list is, and he looks at it and he's like, Utah. And I was like, okay, but there are 15 other things on that list. Can you help me? I wanted to go to one that's, top program, this and that. I actually really wanted to go to Brown, because there's a woman there who I think is a really amazing person and surgeon. I wanted to have her as a mentor. And Ackelman, their chair, was just our visiting professor. And so I had talked with him and I felt okay, this is it. And I think this is how we know that these back, discussions on the phone happen, is I was pretty sure that was going to be it. And I felt like I'd had a good rapport and I'd been authentic to myself. So he's a huge Yankees fan. Hand interviews are starting around now. I showed up and I was like, the Yankees just won the Super Bowl, right? And he got it. Right? He got that I am not going to be able to sit here and talk to you about baseball statistics for 15 minutes. It opened an opportunity to get to know each other. And that was great. So I'm like, okay, I felt better about that. I go on my Utah interview and they ask me, so I felt great from Brown. I go to Utah and I'm the last one they interview, in the S's, and I got asked by Angela Wong, like, what's your vice? And I thought, vice, like, what, this is a weird question, you know? And I was like, trying to go safety answer, right? And I said, I eat ice cream. I love, and she's like, that's boring. Like, you've got to have something else. Like, well, this is really like digging deep. I'm like, well, can you describe to me what a vice is? And so she says, it's something you do that you don't really want to tell other people you're doing. Like, one guy told me he sings to Michael Jackson really loudly. And I was like, okay. And I was blank. And I was like, I picked my nose on the way home from work, like when I've been in the operating room and it's really dry and I haven't had anything to drink all day. And she was like, that is weird. And so I thought for sure I was not going to be a fellow there. I walked out the door feeling like I'd failed, right? And then lo and behold, I matched there, and I remembered what Dr. Light said. Utah. He's a man of few words. I think probably you guys know that. And so from there, it's this like passing on to the people So this is the like job opening, posted for a long time. And this is where your bias is right. Like the job is open because it's not one that people really want. It was a really hard 4 years for me. And I did some really great cases, like it's level 1 adult trauma center. So I started in adult. There were fellows to train. The Peter Stern, fellowship is there. But the culture in the hospital and the culture in the department was a really challenging one to navigate alone as a woman. And I didn't, even though I did reach out to some of the other women, it didn't translate there. So I ran some more. And that's where I find time to think. But I had this experience when I figured out that I was like, the culture didn't fit for me. Was I went into work and there was another surgeon that was there in the surgery center, and I was putting my lunch up, and he said, you know what's wrong with this country? And I said, no, tell me. And he said that women work. And I was like, I didn't know what to do, right? Like I haven't navigated this before. And I just put my lunch up. And so I like say, should I take my lunch back out of the fridge and go home? Like, could you do my cases for me today? I'm trying to get humor or something, anything. And he just was in his own mind, right? He wasn't willing to have the conversation. He just wanted to talk. I don't know. And he got so like animated that in talking, I was standing and he was sitting. So if you pay attention to with the way communication happens with your patients, this is why you sit down when you talk to them. He was below me and he didn't like it. So he stood up and he pushed me. So I was then sitting. Right. And I was like, okay, like that seems wrong. But I just that was it. Like I did my cases, the day was over. I went home not long after that for Thanksgiving and was telling my family about it because I just normalized it. Like, this is the culture of orthopedic surgery. This is the culture I'm in. And my dad says, like, is that guy still working at your hospital? And I was like, what do you mean? He's like, you didn't tell anyone? I said, no. Like, what? That doesn't make sense. Like, who am I going to tell? I'm alone. No one's going to help me. So I get back and decide I have a coach. So that's actually that's one of the greatest gifts that they gave me there is they paid for executive coaching for me, I think, because they felt like I needed it, but I recognized the benefit in it. And I asked her, like, what do I do? And she says, you can go to HR, you can go to your chair. And like, the only thing I knew about HR was that you don't ever want to be there. And you don't ever want to go there. If you watch like The Office, I think that's how they portray it. And it's pretty much true. And so I went to the chair and he really downplayed it. And he said, it's done. And it didn't go anywhere because I knew it wasn't going to. But I also learned from that experience to know that that wasn't the culture I was going to really grow in anymore. But while I was there, I like really strove to figure out how to be a better mentee, because I felt like I was the one who was failing. Right. And I started to look at like, okay, I need to make my 5-year plan, my 10-year plan. Like, what are all the things that are going to go into it? And we have so many different things that we do in our in our lives as academic educators, that like, how do we be good at everything? And I always go back to Terry Light's statement when I was a resident, when I asked him that question, and he said, take good care of patients and the rest will fall into place. And I do think that that's true. What he didn't say is, and also make a 5 and 10 year plan and figure out who can help you. But that's where I'm not sure if that is that implied. Like, do the guys just know that? And I didn't. But it was irregardless. I always fall back to this, and that's why I started the last talk with it, right? Because it's really, we're here to take care of patients. Is what we signed up to do. So this is me. It's an excellent suggestion, Ms. Triggs. Like, perhaps one of the men in here would like to make it. That's how I felt when I was there. Like, people weren't. I might have good ideas, but if it didn't come from one of my colleagues, then it wasn't, accepted. But on the way out, it had changed. This was the trainees, but all of a sudden we've got a bunch of women, that are there. So it does show that having people there, it does help with the culture change. But if you don't change the culture, there will be attrition. But I met, when my mind was my 5 and 10 5-year plan, at least in your first number of years in practice, you just want to get board certified. So I did it, right? I passed those things. I became a full member of the hand society. I mean, as a hand surgeon, this takes 4 years. I think that's the right number. So that's a long time. But I also was accepted as a young leader in the hand society. So I knew that like I must have done something, because that's not that easy to get. And I survived, right? I took a break. Like at that point, as I was leaving, I needed a break. I needed to reconnect with who I was. So I applied and got this young surgeons overseas trip. And all it said was, you have to utilize your expertise in the field by improving the quality of hand surgery in their country. And so I didn't know what to do with that. So I did 2 things. One is I just did all the hand surgeries, because that's all they wanted when I was there. I went to Bhutan. But I educated the medical students, and I got this text message less than a year ago by the guy who I was teaching to do casting. He's in the front. He's a general surgeon there now. And he did a spaghetti wrist just like I taught him to do, right? And so that it doesn't always, the changes that you make and the things you put in place we want instant feedback. We all do. That's what Facebook gives us. That's what we want as surgeons to some degree. But sometimes it does take the time when you go and you're a part of the culture and you start to make the change. It takes a little while to see it. So then here I am, like I'm super excited in my current job. I'm moving to my hometown. I'm becoming a peds hand surgeon. Half the department's women. It's the unicorn in my mind, right? But now I'm there for 5 years, and I know that unicorns don't exist, right? And so I think that it's this matter of setting our own appropriate expectations. Like, I'm a spiritual person, not really religious, and I think that this is said also in AA, and that's not a part of my life for myself personally. But is the Serenity Prayer is really actually meaningful, particularly when we work in these big hospital systems, right? And as surgeons and everything else. And the key to it is that we need the wisdom to know the difference of what we can change. So when all these things are around us, it's to boil it down to what do we have control over or influence, right? And so now I'm in this new place. Like, what's my plan? What am I going to make it out to be? And I'm back to this: take good care of patients and let the rest fall into place. Well, when you get there, you have to figure out, like, what's the department structure? What's your healthcare system like? And what's the patient population? What resources do I have to be successful in all of these, 5 academic arenas? That's where it's helpful to have leadership that will help you to understand that. As getting into research in peds hand, it seems so niche, but really, it's really such a small part of hand surgery, and each injury is different, or each congenital thing is different. So I've had to really try to figure out, in this realm where I have a small N every time, how to make a difference, right? And so what I recognize is I was doing a lot of forearm malunions, and I used Materialize, which is really helpful. because there's always rotational deformity. And I started to wonder, okay, these kids are waiting like, you know, they could have just had it pinned when it first happened, but now it got treated in a cast, and a year or two later I'm doing, because they're dislocating their DRUJ or they're having pain or whatever it is, and now they're out for like 3 months, 4 months waiting for these osteotomies to heal. I'm back to my curiosity, right? Like, how can I do better? And so there are no clinical guidelines. So I designed a project to look at Salter-Harris 2 fractures to try to create those guidelines. And just, you know, but this stuff takes a while to figure out what the right question is to answer and what's going to get accepted, you know, and I'm excited it got accepted at POSNA. And I'm not trying to be a humble brag, but the point is, like, I figured out the right question to ask, but it took me a few years, right? And the thing is, and it takes a team. I didn't do this alone. I didn't measure a couple hundred x-rays to figure that out. And so what I did was I utilized my work and summer scholars to do that. So we have a research program, which, and this is the DEI answer, like, I am using as the leader of that. My goal is to give people the experience through this program, right? And so the folks who help me do all of those measurements, who help me to be successful, I'm turning around and helping their career as well by doing that. So I think, though, with this research, I want to get through like a couple more slides. Okay. Because I think it answers your question. So sorry, the groundwork took a while to lay down. Is that, like, at our research meetings, I was starting to see patterns in the projects that we were seeing, like delay in access to care for athletes. We did a scaphoid non-union, it came up in ACLs. And I started to wonder, like, it's the Black athletes in our community that have a delay in access to care. Like, why is that? And so that's the curiosity, and that's the, like, focus on the margins, right? If all we do is just publish, like, that there's delay in access to care and that's it, and you know, we've all read those articles over and over again, we need to explore this further. Like, this is where we make the difference, I think, is when we start exploring that further. Why is that happening? But Cerner is what we use, isn't going to give us the answer. And so I went to our research institute and found the people that are doing formative research and asked them to help me design. And you all may already be doing these projects, but, like, this is my learning journey. Help me design these projects, start with one, to go do interviews of the athletes, and specifically the ACLs, because we have a good registry of these kids, and their parents, to find out what that is. But this is a process that, like, we don't know how to do because we didn't learn it in orthopedic surgery. So we have to partner with our research institute, right? And it also involves money, which is why I knew about the AAOS grants that are happening, right? And so I think that as we start to dig into, instead of just saying these are the complications and these are the patients who don't do as well, we start to focus on the margins. We start to focus on the 1% and 2%. And I know that seems like the reason we avoid it is because it's not cost effective or whatever it is. But what can we learn by changing our research a little bit and trying to figure out what's making that difference? I'm on the subcommittee who reviews before things go to the IRB, just in our department. And one of the exclusionary criteria somebody put was non-English speaking patients. Like, record scratch, you know, like, we're just going to leave them out because they don't speak English. I found out our IRB pays for Spanish translation. So, like, we don't have to pay for that in our research funds. I don't know what the process is here. So all of a sudden I'm like, when I see this, I'm like, I'm being stabbed by my unicorn job, you know? And so how do we move the needle on this? So how do we now, for this research, like, how do we ensure DEI concepts, inclusion of all of our patient populations into our research? You know, and I'm, like, constantly trying to figure out synergy, how to work together, how to use our processes that we're doing to interweave this in. And I had just a year or two before, as the QI person, I was trying to QI the research to help the researchers figure out what how the projects they were submitting were meaningful. Like, so we could figure out how to focus our research, right? And we had a scoring criteria, like did they do a good enough lit search, right? So these things are kind of basic, but as we're submitting our projects, like to see, and this is the long game, this is the infinite game of what project submissions are going to be successful. And this is a bottleneck, right? So this is like when you submit your project, in order to get it in there, you have to do this evaluation for the committee to consider it. So it forces you to evaluate your own project and them to evaluate. So this is the place I decided if we're going to drive our research towards including health equity, we should include in that part of the evaluation health equity questions, right? It seems like maybe you're already doing this here, so I'm sorry if I'm telling you all stuff you know, but I'm working with the fellow right now to figure out what questions to ask, because there is a very long list. This is it, in an article that came out a couple years ago of what to ask. And I'm like, that's too much reading for an orthopedic surgeon. So we've boiled it down to 2 questions, and we're about to roll it out now to start seeing how it goes and seeing how people are answering their questions. And so as you've seen in this path, like I'm a rules person, and I try to figure out like, when you know the system, right? When you know sort of the rules of the way you engage at work, like where can you put these pieces in? How can you change it? And I realized that as a part of my 5-year plan, like I know I'm doing this, but I have my like promotional plan. If I look at what I need to do to get from assistant, associate to full professor. And when I do all of those things, I want to make sure, I mean, I have another column like that I have, like, I've got women, women, underrepresented minorities on all those projects, right? So it's another column to all the projects that I'm doing, to use that as a platform to support the diversity efforts in. So it might just be putting one person on one project, but also those projects are asking the question of how we can do. So I think I appreciate I'm getting the pull, the time to end it. So the advice to little me is to hang on tight, to stay curious, to live up to my name, and to stay in the wilderness, to keep asking these questions. So thank you all for staying late. And I'm going to end it there.
Any questions? I know we have a lot of people who have to head out.
Thanks, Micah.